Rolling.
Basic cystoscopy is an important skill for every obstetrician and gynecologist. In this video, we will go through the basic steps of assembling a cystoscope and conducting a basic diagnostic cystoscopy. Assembling a cystoscope. There are three general parts to the cystoscope. They are the telescopic lens, the cystoscope bridge, and the sheath with or without an obturator. These are connected with the light cord and camera to provide the image on the monitor. The lens is the working element of the cystoscope. It is the most delicate, and if accidentally bent, it can be destroyed. The bridge and the sheath have ports with stopcocks that allow for in- and outflow of fluid to distend the bladder and for placing instruments through the scope. The light source cord allows introduction of light through the scope. The camera allows visual images to be captured and displayed on the monitor. As a side note, the cystoscopy can be carried out without the camera with the surgeon directly looking through the lens. To start assembly, first you connect the bridge with the sheath. You will have several options for size of sheath. Select the smallest size that allows you to accomplish your task. Generally, with a diagnostic cystoscopy, you want to use the smallest sheath available. Larger sheaths are used to allow the passage of instruments through the scope into the bladder. When connecting the bridge to the sheath, pay attention to line up the notch on the sheath with the tooth on the bridge. This will snap into place. Check for security. Next, select the lens necessary to accomplish your task. Generally, for a diagnostic cystoscopy, a 30 or 70-degree lens will allow for complete visualization of the bladder mucosa. For intravesical procedures, a 0 or 12-degree lens allows you better working visualization of your instruments. The lens is inserted last to reduce the risk of damaging the lens through accidental bending. Insert your lens into the bridge sheath. Take care to line up the notch and the tooth so they fit together. Turn the collar clockwise to lock. As a rule of thumb, the light cord post will be opposite of the bridge accessory port. Some lens bridge connection mechanisms are click and some are collar. Make sure you understand which mechanism your device uses before attempting assembly. Never force anything. Next, attach the light cord. Some snap on, some screw on. Again, familiarize yourself with the connection mechanism prior to your attempt. Check security after you've connected it. Now, attach the camera to the lens. Familiarize yourself with the mechanism used to connect these two parts and check security. Finally, attach your inflow. This can be done through any of the accessory ports on the bridge or the sheath. However, it is most commonly done through one of the ports on the bridge. Once your cystoscope is assembled, turn on the light source and the camera. Now you are ready to perform your diagnostic scope. Make sure to turn your light source on 100% and white balance your camera. Each camera will have a different mechanism for performing the white balance. Make sure you are visualizing your entire field on the screen. This may require manipulation of the camera's zoom feature. Then turn the inflow on prior to entering the urethra. Guide the scope into the urethra at roughly a 45-degree angle to avoid urethral injury. Allow for distension of the bladder and then turn off your inflow. Bladder distension can be recognized by the awake patient reminding you their bladder is full. In the anesthetized patient, it can be noted when the detrusor musculature becomes pronounced. First, orient yourself in the bladder by identifying the dome. You can do this by rotating the light cord to the 6 o'clock position, which will be denoted on your screen by the black arrow. You can confirm you are looking at the dome by seeing bubbles at the top of your screen. Then find your ureters. To do this, rotate your light cord to the 12 o'clock position and follow the back wall of the bladder down to the base. You will find the ureters in a straight line with the trigone. Watch each ureter to ensure normal ejection of urine. The bladder trigone defines a portion located on the posterior wall of the bladder, bordered by the 2 ureteral orifices in the bladder neck. Visualization of the trigone is achieved by aligning the tip of the cystoscope inferiorly immediately after passing the bladder neck. The interureteral bar extends between the 2 ureteral orifices and appears endoscopically as an elevated part of the mucosa. The ureteral orifices may have a variety of endoscopic aspects, but in general they appear as small circular or oval openings situated on top of a mucosal fold. With the peristaltic outflow of urine, the ureteral orifices open and the mucosa that borders them retracts inward. Cystoscopy is helpful in identifying foreign bodies, such as a loop of proline suture in the bladder, or multiple bladder stones, or transitional cell carcinomas, or papillary bladder tumors, carcinoma in situ, which looks like erythematous bladder lesions. Cystoscopy can also help identify interstitial cystitis. It can appear as inflammation with petechial hemorrhages, known as glomerulations, before or after hydrodistension, or there can be the presence of Hunner's lesions. Or a vesicovaginal fistula, classically noted in the midline above the trigone. It appears as a simple hole with a mature fistulous epithelial tract. Cystoscopy can be helpful in diagnosis and treatment of several bladder issues. Hopefully this video was helpful in introducing you to performing a diagnostic cystoscopy.